public call for the Gravity Project. We're going to be covering our 3 current domains, health literacy, medical cost burden, and health insurance status. My name is Sarah DeSilvia, and I'm the Director of Terminology, and my friends will come and join me in later parts of the call. Next slide, please. As always, we welcome you to join the Gravity Project community meeting. Folks are usually muted upon entry. This is just because we get close to, in normal calls, upwards of 100 plus people. We ask that you remain muted to avoid background noise. All calls are recorded. Recordings will be available on the Gravity Confluence page. Everyone is encouraged to participate in any discussion using the WebEx chat feature in the bottom right of the WebEx meeting window. I do work very hard to make sure that any comments within the chat are included in the conversation, and we do often stop the presentation and unmute if there's elements that need to be reviewed. Please send chats to everybody if you want them to be part of the conversation, just so we can make sure that they're included in the conversation. Next slide, please. This is our standard antitrust practices slide. Next slide, please. As always, we invite you to officially join the project. You can officially join the project on the Confluence via the link. You'll see over the course of the presentation any of the links that we discuss in our work drop into the chat. If you want to check whether you're a member, you can check on the Confluence. And if you want to know anything and everything about the Gravity Project, that's on the Confluence as well. Next slide, please. A big thank you to our project founders, grantors, and in-kind support to date. Our support is spread across vastly, like our 5 different stakeholder groups, and we have many, many members that work together to make sure either through their monetary efforts or their labor, we can collectively get the work done, and we're just incredibly grateful. Next slide, please. We are seeking additional sponsorship. So we do rely upon sponsors for sustainability. If you want to be a sponsor or learn more about sponsoring opportunities, you can send an email to gravityproject@emiadvisors.net, or you can visit the Confluence, and there's a Gravity Project sponsors page. Next slide, please. This is the agenda for today. I'll go through announcements briefly, introductions. We have 2 really exciting and wonderful new members of our team. We'll go through the project schedule and overview. We're going to lead off with tech today with Bob talking about technology updates and the Connectathon. Then we'll close with our concepts and terminology work. This is to allow Bob to be here when he's able to be here. And then we'll close with community homework and next steps, as we always do. Next slide, please. Announcements, next slide. So we do just want to make sure that everyone's aware of our and can review our formal responses to the 2 different, well, the first for the RFI on strengthening community health through technology. Public submissions are due March 31st, 2022. Mark, I don't know if you want to, are you on the call? Do you want to speak to this more if you're free? Looks like he might not be on the call. We also want to mention the Gravity's response to the CMS Medicare Advantage and Part D proposed rule. Our colleague and community member, Mark Savage, who's our policy lead in the project, worked very hard on our submissions there, so we're grateful for him. As always, thank you. As always, you can always see more information regarding Gravity's announcements on the Confluence pages. It's just a partial view. We do try to make sure that the community is aware. If there's anything particular that you feel like is relevant for the whole community, just send us an email and we'll see if we want to include it in our Confluence announcements page. Next slide, please. So how to see the response to the White House RFI, that will be on the Confluence. Just for the question in the chat. And then, Gabby, do you want to speak to the pilot affinity groups, pilot work group, since that's your area? That'd be lovely. Welcome. This is Gabby.
Hi, good afternoon, everyone. I hope you can hear me okay. With headset, sometimes I'm on mute by mistake, but thank you for giving me, a few airtime. We are very excited to get started with Pilots Affinity Group. Our Confluence page will be published hopefully by next week, definitely by the end of March. We'll have a interest form that you can submit, very similar to the way that you have joined the Gravity Project. We're looking for pilot sites under the roles that are listed here on the slide. So referral source, care coordination platforms, referral recipients, referral recipient light. You can submit your interest to our email at this time, and once the Confluence is up and running, we'll be able to collect your interest through there. Feel free to contact me there. Any questions, I'll be on for the rest of the call.
Any further questions on the pilot affinity groups work? Again, if you have any general questions or you want to submit interest to pilot, you can submit it through gravityproject@emiadvisors.net. We're really grateful to move to the stage where we have product to implement and test, and we're really grateful to use whatever we learn through our piloting to make sure that our products are meeting the needs of the community and our intent and our use cases. So looking forward. Yay! Next slide, please. Introductions. Next slide. It is my honor to pass the mic to our new Gravity Program Manager, the amazing Jillian. Jillian, do you want to discuss, introduce yourself?
Yes, please. Thank you for the opportunity. And hello, everybody. I am Jillian. I am serving as the Senior Health Equity Manager on the EMI team. And in that role, will serve as full-time project manager, or program manager rather, for the Gravity Project. So I'll be supporting all of the work streams, advisory councils, and supporting Evelyn and Sarah and the whole team in sort of the data.
Jillian, your sound is sketchy, so maybe if you mute your video, there you go. If you turn your video off, sometimes it works better.
Thank you. Okay. My background's in public health management, policy and management. Is the sound better, Sarah?
It is indeed, yes.
Okay, with a focus on chronic disease prevention and health promotion. And I have professional licensing in project management, change management, and lean principles. So I was actually a community member of the Gravity Project in the past year or so. I was joining these Thursday calls, like all of you, and I'm so grateful to be now supporting the work in a greater capacity. In my last role, I worked as a project manager at the largest F2HC, Community Health Center network in New York State, where I was in the quality and improvement and population health department. And I partnered with some of you on this call during my time there. I was more on the implementation side, supporting a variety of quality improvement projects aimed at driving performance on our clinical quality measures, including development of clinical decision support tools, our virtual care delivery program, and a prescriptive pantry program around food insecurity assessment and intervention, as well as some prepare pilots. So prior to that, I was at a county health department, and I'm just so excited to apply my experience in this sort of work in this space and in multi-sectoral, multi-stakeholder convening of groups to focus on this very important project with all of you. And I aspire to do so always with a health equity lens, and I'm just so humbled and happy to be here to support all of you and to support the program. So thank you again for the time, Sarah.
Jillian, we are so glad to have you. Both of our new members, we have the luck of coming to join us because they got our why, right? So we are so grateful to have Jillian join as our program manager, and it's a mission-driven alignment coming here, understanding what we do and wanting to be part of it and help us and take it to the next level. And then I'm also grateful to introduce a new member of the terminology team. Next slide, please. We are super, super grateful on the terminology team to have Himali join our group. Again, another mission-driven person who is very accomplished in her other life, and just like Jillian is joining us to be part of this work. So Himali, do you want to briefly introduce yourself?
Sure. Thanks, Sarah. Hello, everyone. This is Himali Setwal. I'm a physician and an informaticist by background. I have been in the field of terminology for, I think, over a decade, and most of my work until now, it was centered with patient care, especially standardizing data mapping, data modeling, health information exchange at state level. And most of my work was funded by US government. One of the larger projects that I worked on is data standardization for 35 clinical domains on VA and DoD side, where we were trying to meet the interoperability between those two departments. I have also served as a subject matter expert on a medication terminology called NIRARTI. This is the terminology owned by VA and used by FDA. So whenever new medication would come into market, I was the subject matter expert to evaluate it and put it in the right place in the hierarchy. So a lot of experience in data mapping, modeling, health information exchange, but most of that was at patient level, and I really wanted to be part of Gravity, where I can transition that experience from patient-based to a community-based level. And I'm really grateful that I found the right place for myself to grow and to help and support the community. I'm very excited to be part of Gravity team, and I'm really looking forward to contribute to its success. Thanks, Sarah.
Molly, we're so grateful for you. If all of you could have been in their interviews, you would have heard two people who are really, really excited to join our work. So grateful. Welcome, Jillian and Himali, and welcome to the family. It's great to have you here.
Thank you.
We've come a long way, friends. Next slide, please. All right, next slide. This is the roadmap. It hasn't changed very much. So here we are in health literacy, health insurance status, and medical cost burden. Getting ready for another Connect-a-thon, which Bob will talk about later. Working through ballot reconciliation that Bob will talk about very shortly. And it's kicking off our terminology and technical pilots that Gabby just mentioned. So knee deep in the work, and we're really grateful that you all are here to be part of it. Next slide, please. Any questions on announcements and such? Okay, next slide. We are flipping the presentation, and I have the honor of centering the voice of our dear friend, Bob Dieterle, and to help us go through the technology update and some announcements regarding the Connect-a-thon. Welcome, Bob.
No, Sarah, thank you very much. Appreciate it. We're going to have to do this fairly quickly. I do only have 15 minutes, so next slide, please. All right, we are in the process of doing ballot reconciliation on the second balloted version of the SDOH Clinical Care Fire Implementation Guide. We have added to this guide a number of things that we'll go through in detail, but primarily related to exchanging information with applications, whether it's a client's application or a CBO's application, and adding in some draft specifications that we're using for what we're calling personal characteristics going forward, that focus initially on race and ethnicity. The ST1 version, the Standard for Trial Use version 1, was published in August. We balloted this version in the January cycle. It closed on the 10th of January. Next slide, please. Okay, broadly, ST1 is the blue lines. It basically provided all the standards for communicating SDOH information between fire-enabled organizations that are part of our ecosystem: providers, payers, government entities, coordination platforms, community-based organizations. The STU2 focused on connecting those that did not have fire enablement. So the orange arrows, and those orange arrows can occur virtually anywhere, but particularly around the patient and community-based organizations. Next slide, please. What we did primarily was add support for a patient or client workflow. So the ability to go in and support questionnaires, cancel referrals, request information, exchange supporting information, providing contact information with an individual that's involved in their own care. So we created separate tasks for both referral and patient workflow, which allows us to manage them independently and using different statuses primarily. Synchronization process is part of what we designed. So these applications can go and make sure they have up-to-date information without having the individual needing to understand the underpinnings of authentication and authorization. So think of it like Outlook, if you happen to use it, and its ability to synchronize with multiple email systems. Very much the same concept. We adopted more U.S. core value sets because they had expanded the scope of them. And then we added support for both VSAC, which is where we're putting all of the terminology value sets that are being developed by Sarah's group, and with the exception of those related to LINC codes, different problem there regarding assessments. And we introduced the idea of supporting 211 LA taxonomy. The work is underway to go and develop the statement of understanding between 211 LA and HL7 so that we can use 211 LA codes for examples. And then ultimately, you're still going to have to go and contract with them to get the right to use it in production. We'll talk about race and ethnicity in a second. Next slide, please. Okay. The way we handled adding in the codes that are specific to the work that Sarah's done, basically those codes that are published in VSAC, is to go and focus on those codes that are relevant to a particular problem, like condition, think diagnosis, health concern, et cetera. And so in VSAC, there's a list of all of the elements for food insecurity, for ICD-10, food insecurity for SNOMED CT, housing insecurity for both of those other domains as Sarah's group has been defining them, all rolled up into what's called a group value set that is now referenced by, at the moment, the new version of US Core. It'll be referenced in our implementation guide. And at this point, you can use that value set. In fact, you should use that value set if it represents the value you care about. Or you can use the entire set of ICD-10 and SNOMED CT. Over time, we'll push the preference to the work that Sarah's done and the VSAC value sets. But for right now, because the work is in process, we've left it open so that people can use what they need to use to appropriately describe various social determinants of health. Next slide, please. Race and ethnicity. The current process for describing race and ethnicity in HL7's FHIR is an extension on what's called the patient resource. It only applies to the patient resource. You can only describe one simultaneous representation of that. What we learned is there's a need to describe more than one representation because depending upon how you collect it and who you collect it from, it may differ, but they're equally relevant. And we're not trying to pass a value judgment on which is the only correct way to do it. So we're doing it using a profile in what's called an observation to represent this so that we can have simultaneous versions. We also can protect that information independently of exchanging patient demographics, for example. We've, in addition, allowed it to apply to the practitioner and the caregiver, where we have representation of that information and need to exchange it. One of the things we have done is in working with HL7 and the cross-group products work group and the vocabulary work group and the gender harmony project is realize race and ethnicity aren't the only, quote, personal characteristics we need to support. And we're doing this to go and evaluate them. We're not doing this because we have made a decision that this is the right way or the only way to represent them. So what we're doing is adding to this ability to support observations, sexual orientation, gender identity, recorded sex or gender, and personal pronouns. And we're in the process of working up the profiles to support all of these to be tested at the May Connectathon. We'll talk about that in a second, and tested again at the September Connectathon. And our expectation is we'll sit down and take a look at how these work versus extensions to the base resources and make a decision as to which way to go. And it could be one way or the other. It could be extensions. It could be observations. It could be both. So this is work in process. Next slide, please. I have a question here from Lucy. How about patient's ability to correct the record? Will that ever happen? Good question. I think by having this as observations, it makes it easier, but we'll have to take a look at that. And that certainly is part of what the one of the work group efforts at HL7 is focused on, is how do we get the patient have the ability to correct information in the record. Okay, technology update. We are working on resolving the ballot comments. We had 100 of them, plus some things that were left over from before, things we deferred to the future. We have resolved 35 of them. 20 have been voted by patient care to incorporate in the implementation guide. 15 are waiting for the next block vote. We vote them as a block. 14 of the tickets are technical corrections, which leaves 52 comments to be resolved. Now, let me make sure we understand 52. We spent our entire session this week on resolving one and proposing, but not resolving two others. Depends upon the complexity of the ballot comment. We could take more than 1 week to resolve one. We can resolve multiples in a week, depending upon the nature of it. Our expectation is this will continue on through in May, June timeframe, and ultimately publish the next version of the guide in the June, July timeframe. Next slide, please. We are coming up on another Fire Connect-a-thon. We have these 3 times a year. We have one in September, we have one in January, and we have one in May. It's time for the May Connect-a-thon. It'll be May 2nd through the 4th. The actual work will be primarily on the 3rd and the 4th. It is a virtual event, and here's a link to register. And you do have to register if you wish to participate. Next slide, please. We are testing the following actors: clinician-facing systems like EHRs, intermediary platforms such as coordination platforms, health information exchanges, community-based or other social care organizations, survey forms or application screening tools, payer health IT, and patient-facing applications. Next slide, please. These are all the testable interactions. Sorry, go ahead.
Excuse me, does one have to pay, if you go back to the previous slide, does one have to pay to participate in this Connect-a-thon?
You can continue forward. The answer for HL7 is always yes. There will be a Connect-a-thon in July sponsored by CMS that we will participate in where you do not have to pay.
Will there be the patient-facing application element in that July event?
Yes, there will.
Thank you.
You're welcome.
This is Catherine.
Continue forward. Sorry?
I'm sorry, I have a question about community in the CIE partners. Is that something that we would roadmap alongside of the Connect-a-thon if you have a community information exchange?
Yeah, consider it the same way as a coordination platform or an HIE. Basically, these are organizations that sit in the middle and facilitate the exchange of information between the various stakeholders.
Perfect, thank you.
Does that make sense?
Yes,
yeah.
Thanks.
Okay, these are the various interactions. This is kind of a redrawing of the one we had before, showing the orange and the blue arrows. Next slide, please. These are the direct referral opportunities. We actually have 5 different work streams that we'll do over the 2-day period. One is related to referrals, as you're seeing here. We have both a direct referral without an intermediary. Next slide, please. We have a referral light where we're actually not using fire to fire, we're using fire to an application. Next slide, please. And we have an indirect referral using a community platform or an HIE or a CIE. So that's one. Next slide, please. We have patient interactions that we'll be working on, including the ability to do authorization, authentication authorization for synchronization. Next slide, please. We have a couple that are missing. We're testing also our ability to do assessment surveys using link-coded assessments. And we're also testing our ability to go and communicate, although this was in the light version, our ability to communicate directly with CBOs that have their own applications. They're not Fire enabled, they just connect to a Fire API. So come join us. We want anyone and everyone to participate that can either learn from what we're doing or bring code to the table and test with us. And then here's an open invitation to come and participate on our ballot reconciliation that we do on Wednesdays. And I think that's it. Next slide. Yes. So any questions or comments? Rita, is there a subgroup focused on? Yes, that's just a comment. Yes, there is a subgroup focused on, oh, severance from corrections, okay. Patient identity proofing, where does that come in? That's a really good question. Identity proofing work is going on in FAST. There's some work that is available coming up for ballot in May regarding identity proofing individuals. So you may want to get involved with that. Are the slides you showed available on the site? They should be. Sure. Thank you. So thank you very much for the feedback. Any other questions before I leave?
Yes, please. The website that has the Exchange workflow, it doesn't have the same notation that you were presenting in the slide. I think the one that you're presenting in the slide very easy to read versus the UML notations. Where can we find
which one are we talking about now?
The workflow?
You mean the three ones with the referral patterns we're testing, you mean?
Yes.
I assume we'll post these. Okay. We can post this as part, you're talking about the track page.
Say it again?
You're talking about the Connectathon track page, correct?
The one on HL7, the Exchange workflow, general workflow has the boxes, but doesn't have the same notations that you're presenting in the slide.
Can you go back to go back?
Yep.
Go back.
Yeah. So see this notation. So where can I find those slides or those notations?
Oh, that didn't get updated. I apologize. Go back.
Yep.
Go back. I forgot to update these. My fault. Go back one more.
Yeah, and this one too. Yep.
One more. I will get an updated version out. The gravity track down here at the bottom is the one that has all the workflows on it, the use cases.
Do you mind putting it on the chat?
Our team can help with that, Bob, so you can go to your next thing.
Yeah, why don't you go ahead?
We'll try.
I'll tell you what, I will find it and post it, but I do have to drop off, okay?
We
So
appreciate
thank you,
it.
everyone.
Charles, we'll get those to you, okay?
Thank you.
And to everybody. Really appreciate Bob swinging in. Thank you, Bob, even though you're gone. We appreciate you. So we flipped the meeting, and so now we're going to go into terminology and cover some of the terminology development for our 3 domains. Next slide, please. Next slide. First, I'm going to pass the mic to the amazing Linda Hyde. Linda, do you want to give an update on ICD-10-CM?
Sure. Thanks, Sarah. Yeah, just a quick update on the Coordination and Maintenance Committee process. Sarah presented at their meeting earlier this month. Comments on our gravity submission must be submitted no later than May 9th at this email link right here for the NCHS ICD-10-CM. We encourage you either to submit comments in support of our request. You can either draft your own submission to email to them, or you can use the form letter that will be provided in the link. that we've drafted specifically for the concepts that Sarah presented for this meeting. And in order for you to review the entire submission, the final submission, we've identified on the Confluence, there'll be a link that you can use to get a copy of the diagnosis agenda. And the Gravity submission starts on page 81.
Thank you, Linda. We do want to note that the agenda and packet that was presented at the meeting had slight errors, so the updated agenda and packet is available now. I want to thank you to our friend Sue Bowman, who sent it hot off the press to us earlier today. Oh, I'm so glad that some of you were able to come to the presentation. It was really wonderful to represent the collective work, although some in the greater community might not know how many of us we are. It's always an honor to represent us out there in the world. So I'm really glad some of you were able to be there, and I actually saw some of familiar faces in the members and the commenters. Aw, thanks. Next slide, please. All right, you've heard me say this, so we are getting together a work group to just kind of reflect on some of the build decisions that we made for our terminology development. We were doing novel and innovative work, and so when you're doing novel and innovative work, you make hypotheses. And so we really need to make sure that those hypotheses we've made and the terms we're building are useful. So we're convening a monthly task force of implementers to assist with the evaluation of Gravity terminology. Just write us if you want to be part of it. We're going to kick that off in early April. It does segue really well. This is kind of like aligned with the Pilot Affinity work group. If we all remember, the proposal for piloting, phase 1 piloting is just piloting terms, right? So if some of us are not necessarily able to pilot some of the referral exchange work or some of the complete elements of the IG, you are eligible, like part of our piloting is piloting the terms themselves. So we really look forward to having you join this work. And again, the key to participation is the Gravity Project at emiadvisors.net email. All things come through that email. Next slide, please. Okay, next slide. We're going to go through some updates on all of our different concepts before the end of the meeting. So we are working on medical cost burden, health insurance status, and health literacy. We are at 317 today. We are still in our collating and gathering of terms across all 3 domains. You're going to hear me make the same plea over and over. We really, really want to make sure that the clinical and community methods that you use to identify these concepts, if you have any standardized methodology for asking patients questions and getting assessments and outcomes, we want it to be part of our work. We've noticed as our team has become more robust, the community submissions have declined. We really do we try to do a very good job querying the community, but we want to make sure that your pathways and processes are included. So please, you'll see the homework. Submit your concepts, submit your desired screening questions and answers that you used in your standardized settings, submit your desired diagnoses, submit any goals that you feel like are relevant to either of those 3, and submit any interventions. And specifically, if you just want to submit programs and program definitions, that's fine. We just want to make sure that we include everybody's work. So if a scale is already in Loink-Sindelin, we still want to have the community submit it. We want the community to submit it even if it duplicates something you see on a slide. Because what we use is every single time there's a second submission of a similar concept that's documented in our process, and so it represents basically like dissemination. So dissemination is one of the elements that we use to prioritize Loink build. And this doesn't count because it's already in Loink, but it doesn't matter if you see it. We want to make sure that we document use. So just submit anything. Great. Next slide, please. And I'm like, how emphatic can I be? Okay, next slide, please. And if anyone wants to remember how to submit concepts, we do document that at the end of the presentation, but there's a data submission area on the Confluence. There's a spreadsheet that you download and then you send it right to us. So it's pretty easy. This is just our grounding slide. We talk about it every time. So the balance of protective forces and protective factors and social risks. Next slide, please. Okay, on to health literacy. Next slide. We really want to give some deep appreciation to a health literacy subject matter expert we were able to talk to in depth for a little bit. Her name is Jennifer Pierce, vastly brilliant human individual who helped us frame some of our approach. So we just wanted to give some updates on health literacy. So one is that right now we're focusing on the differentiation between personal health literacy and organizational health literacy. You'll see that over the course of the next few slides. The reason why we're doing this is because there's really so many different subdomains of personal health literacy. And if we build it this way, we can expand concepts in time. The lack of submissions from the ecosystem means that we need to kind of like taper our approach so we're not building things that aren't useful. So we're focusing on personal health literacy and organizational health literacy for right now. And that's it's been guided by the advice of our subject matter experts that we're working with. Next slide, please. In our conversations with subject matter experts, it was very, very clear that from an ethical standpoint, the focus on the ecosystem is organizational health literacy. You're going to see me go through some different screeners over the course of the next couple slides to really make that come to light, like what that is. But again, personal health literacy is the measure of my own literacy. Organizational health literacy is the measure of how well I, as a clinician, and I'm Sarah DeSilvi, rural family practice clinician, how well I'm doing to meet people where they are and help them understand, right? So organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So again, in discussion, it's really viewed more and more as the only ethical gap to measure. So we don't measure the literacy of the person, we measure how well we're doing meeting them. It sets a challenge for our structure, but a challenge we're going to have to face in other settings because organizational concerns must have organizational interventions and organizational solutions. So our current framework is very intervention and solution oriented in the classic, I'm a person, I help this person in this way, but we are being asked very clearly to address organizational health literacy. So we need to figure out how to do it in our model. I just want to state that part of the bliss of being in family practice is whatever we're working on and the Gravity Project, I test with patients all day. And I had many patients, I've been working on these concepts and thinking about these elements with patients over the last month or so. And I've had many patients start to say to me, you explain things really well. And I'm like, okay, organizational health literacy, we're getting there. So I feel like this is my little test of change every single time we do a domain. And it's been nice to get feedback as I tried to work on this myself with the patients I see in rural Vermont. Next slide, please. We were asked to very clearly lay out some of the differences between personal health literacy and organizational health literacy because it can be difficult to understand. And I'm just putting these questions here. So you'll see on our current master, the brief health literacy screening tool. So these are questions like, how often do you have someone help you read hospital materials? How often do you have problems learning about your medical condition because of difficulty understanding written information? How often do you have a problem understanding what is told to you about your medical condition? And how confident are you filling out medical forms by yourself? And Denise, that's very kind, thank you. So this is a classic measure of personal health literacy. It's an excellent one. It's very widely used. It's a solid tool. It's already in LOINC, I believe. Right, so this is one of those gold standard, like one of those classic gold standard personal health literacy measures. Next slide, please.
Sarah?
Hi, Lucy, yes?
Yeah, on the previous slide, are there national statistics about the answers to those questions?
Yes, there are. Do you want those? That was some of our case setting for with our kickoff.
Yeah, could you put a link or something in the chat, like does 50% of the population need someone to help them? And
Yes.
does 50% of the population feel confident filling out forms by yourself? Suddenly I'm interested in those numbers.
I imagine you are, yeah, based on your perspective, right? So, yeah, your history. So we'll do our best. What we'll probably do is, I don't know if we can get them for the chat right now during the call, but whenever we have a question like this, we try to put it on the Confluence. So I'll do my best to gather that. from the kickoff slides and from some of the literature we work on within our information gathering, and see if I can get it to the Confluence and then ping you when it's there. Does that sound good?
Sure you don't already have enough to do. Thank you very much.
I know, but we have an amazing team. We can work on this together.
Okay.
Okay, next slide, please.
I had a question as well.
Yeah, hi.
How are you doing?
Oh, hi. Sorry. It's my old friend day. Excuse me. Yes.
So,
Question?
so I had a question about, the whole idea of measuring the organizational rather than the individual.
Yeah.
I guess there is a connection between how, and to the point you were making after that, which is assessing how much the patients or the I don't what I mean, but if the patients would be general, the patients feel about how information is shared with them, and then the tools or the path through which the organization is sharing that information. So how, if we focus on one and not the second, knowing that both of them sort of work together, how the information is received and how it's being provided. How are you thinking through those two parts if we're focusing on measuring only the organizational component?
Oh, sorry. We're not focusing only on measuring organizational.
Okay, good.
Sorry. So sorry. What I was intending to convey in that statement is, just as we recognize that the solutions to social determinants of health are structural in nature, right? That I can give you a food box, but I actually don't solve the problem and to address community food security, living wage, et cetera. That's the same approach that's taken with organizational health literacy. Like, I can solve one person's problem, but ethically, it's really about, does the system meet us all where we are, right? So that was why it was framed as an ethical statement, right? But we do both. I assess whether you're food insecure, I address structural food security. We do those things at the same time.
Got it. Thanks for clarifying.
Okay, so sorry to confuse. But I think it's important to restate, because in the beginning we were making choices about maybe we couldn't do organizational health literacy because of the complexity of figuring out how to do that. But our subject matter experts were very much like, absolutely, you have to try, and we know we're trying with other community, like structural level social determinants in the future as well, with like neighborhood safety, community food access. So they were basically saying, no, you need to give it a good solid go. So here we are. And here's just an example of the organizational health literacy, a classic organizational health literacy tool. You can see this across a couple different very important national implementations. It's the Medical Expenditure Survey. It's part of Healthy People 2030. And many of these questions are part of the CAP survey. So these are questions like, in the last 12 months, did a doctor or health provider, this is the preface, did a doctor or healthcare provider give you instructions about what to do with a specific illness? And then, how often were these instructions easy to understand? How often did doctors or other health providers ask you to describe how you were going to follow these instructions? Did you have to fill out or sign any forms? How often were you offered help in filling out forms at the doctor's or health provider's office? How often did doctors or other health professionals explain things in a way that was easy to understand? How often did doctors or other health professionals listen carefully to you? How often did doctors or other health professionals show respect for what you had to say? And how often did doctors or other health professionals spend enough time with you? These last two are part of the same section. They're not classically organizational health literacy, but they're a packet within MEPS, so we have them all here at this time. So here you can see the difference between the how well I understand, right, and how well did the system help me understand. So this is organizational health literacy, and then the first would be personal health literacy. Any questions? Okay.
I would just observe that Epic has, or somebody has picked up all these questions, because I, as a consumer patient, have frequently filled out forms assessing my visit that contains one or all of these questions. And now I understand what's going on here. It's not just that they want to know, it's that everybody's doing this. Thank you.
That's why we reference the CAP survey, right? So these questions are part of the medical expenditure survey, but they're also part of the patient satisfaction surveys that patients get on a regular basis. This is part of what our subject matter experts are very clear with, is that even though this is a reach perhaps in our process, this is already happening, right? So whether it be through whatever organization sends out your satisfaction surveys for your clinic, this is happening. These questions are standardized, so that information just needs to be translated in a way that we can understand. So they're there.
Now, wouldn't it be wonderful if there were actually follow-up for everybody who said no to all
I
of these?
know. Well, this is where we have to figure out interventions. Maybe our solutions will create an automatic requirement to do so.
That would be great. Thanks.
There is a scoring. So Mike, there is a scoring algorithm. So we can the MEPS survey. We're trying to very clearly demonstrate how gravity builds off of all of the federal and core national surveys, including like American Community Survey, Medical Expenditures Survey, Census, you name it. But I'm happy we're eventually going to have all of those available on the Confluence for everyone to see. But you can see that the answering methodology in MEPS, and then when it comes to the interpretation for CAPS, it's all based on percentiles, because we only use it to score providers at this time. There are, it's a Likert. Usually, often, I'm forgetting the standardized answers, but it is a Likert scale from often to not often. It's something to that effect. Sorry, I didn't have room to put the answers on here, just from a slide perspective. Okay, I think we're good. Next slide, please. My concern is that some orgs use only some of these items. We will recommend, we will put into our, we will, and we have a mission to focus on any like core standardized federal methodology. So we will likely, I don't want to preempt anything because we're still doing our process, but you can expect likely that these questions will be built into LOINC because of their core national dissemination and standardization. And then they would be part of our, they wouldn't be part of the VSAC value sets because we don't have LOINC there yet, but they would be available as part of our sets on the Confluence. Okay, there's been work. Oh, so Amy's asking about digital readiness. You're going to hear us make a statement on digital literacy very, very closely. We have talked a lot about digital literacy and digital equity, especially from a rural perspective, because of I represent rural family medicine. We have lots of rural advocates in our group. We talk about it often. It's one of our future domains to address. Okay, so I hope that answered your question, Amy. So one of the things we wanted to state, and again, this is a plea, a desperate plea. I'm going to use the word desperate. In our survey of the Boston University Health Literacy Toolshed, which is the powerhouse of collating health literacy tools, and in our review with subject matter experts, and in our review of the literature, we have many comprehensive personal health literacy tools of research quality. But these are really robust and long, and they're difficult to adapt to quick clinical community implementation. They add complexity and they add time. So when you add complexity and add time to a health literacy goal, it confounds our purpose. So we really need you to send us whatever brief screening tools for personal health literacy you're using. Pretty please, pretty please. So that is another request that's reiterated from the homework slide. Our assessments that include health. Yeah, so anytime you have a tool that includes some question regarding health literacy, send it, because we have a process by which we assess and address everything. So don't nip anything in the bud before you send it to us, because we'll be able to assess it with our subject matter experts once it's part of the system. So just send it and we'll figure it out once it's here. Okay, next slide, please. We want to just review health literacy diagnoses codes again. Everything. These are, again, a work in progress. We're not doing our end-to-end review right now. We're in our building phase. So right now, anything in bold exists, and everything not in bold is to be determined. So just for clarity, on SNOMED CT, we have unable to demonstrate health literacy and difficulty demonstrating health literacy. Those might be redundant, but they're both there. We're suggesting and considering a very clear statement that documents personal health literacy versus organizational health literacy. So it would be inadequate personal health literacy. We're playing around with this, this is the sandbox, right? So in ICD-10 and ICD-11, right now, on the top, we have ICD-10, other problems related to education and literacy. That's the only kind of clear concept for health literacy at this time. Disseminated outside of the US, right now in ICD-11, we have problem with health literacy. We could propose very reasonably that we have a problem with health literacy ICD-10 code. That would not be a great leap. Yes, so we would love, we do have a mission to address digital equity and the digital divide, and certainly it doesn't address just rurality. We talked a lot about use cases within COVID and access to, remote schooling, et cetera. So yes, we would love to have help on that matter, and maybe we'll try to capture your information and circle back around when we're doing that domain. One of the problems we have to consider when we're doing health literacy diagnoses is organizational health literacy, where to place it. It is an organizational assessment, not an assessment of the person. So it's going to be a little bit tricky, but it might be easier to model in STEM CT. But we are going to try to figure out what to do with that on a general basis. And so this is a work in progress. Okay, I think.
Sarah?
Hi, yes?
Just a clarification, unable to demonstrate and difficulty demonstrating. Is there an assumption about language here, like unable to demonstrate in English versus could easily demonstrate in Spanish or Chinese or Tagalog? What's going on with implicit language bias here?
That is a really good question. I don't know if we do talk about bias of tools. I don't think you could easily state this with bias. So I mean, like, just like you're saying, you can imagine that it could be used inappropriately, but our definitions,
maybe just mention that somewhere, somehow, when
we do,
eventually
yes.
have a product on this subject, that we are making the assumption that the appropriate language is used to assess health literacy or something along those lines.
Well, I think I think we also have already made the statement and continue to make it that, and you'll actually see this on the next slide, is that failure to meet individuals where they are with their own native language, right, is bias, right? And assessing outside of that would be bias. We state that very clearly. And this is where you'll see that in our next slide. Or one of the future slides, but that's very, very clear. And this is part of the problem about some of the tools that have been submitted is they're not some of the tools have many, many translations and some of them don't, right? So this is an area that we do need to consider when we're doing build. There's a lot of questions here. Who would document that the organization has a health literacy problem? Anybody in the team could. And then do we have anyone in our team from IHA? I think we're going to have to look into that. Sometimes I don't know everybody on the team. Organizational literacy could definitely be a part of quality measures, the keys. We can imagine that very easily. It already is in a sense because of CAPS, right? So CAPS become part of the assessment of clinics within value-based healthcare reform. So there is a way that percentile and meeting like patient satisfaction is part of reimbursement already and part of quality outcomes. It is that way within Vermont and our next gen ICO. Our CAP scores are part of our global performance within everything from HEDIS measures to other. It looks like a judgment on the individual. What I'm trying to figure out what that was. Oh, are we talking about the bias statement?
Yeah, I was just looking at what I see on the screen and thinking about how people might use this, in the case of individuals. I don't like the way it's worded.
Which one? All of them?
Kind of all of them, yeah. I mean, they seem like they're meant to measure individual issues, which I mean, I think that's what you're saying is that's what we have now, but how you take this and translate it into an organizational.
Yeah, so these ones right here do not represent organizational health literacy. And this goes back to what we were saying before, that like ethically, organizational health literacy is where it's at, right?
Right, no, got it.
Yeah. Your gut feeling is
I'm agreeing
very
with you.
true,
It's a problem.
right? Yeah. And so we have to figure out a way, we have to figure out a way to work within a bounds within problematic terminology here, but we do agree that the interventions and the goal should be addressing the organizational concerns. So wonderful. So Catherine, if you can connect us, that'd be great. And then Rita, I'm trying to, there is crossover between the education domain, certainly in many of our programs of interventions, and the health literacy domain, if that's what you mean, Rita. Hi, Rita. Okay. I don't know if I answered your, yeah?
Yeah, I'm just trying to remember because I know that that was a few months ago when that came up, but I was thinking more in terms of somebody raised the language barrier issues and also that when I was thinking, well, if they were learning English as a second language, I think that's something that you had previously covered that might
Correct.
also.
Yeah, and you can
relate to
see,
this,
exactly, and you can see we do have all of the ESL programs in our intervention. So Rita, you're exactly correct. Yeah, so if we go next, the next slide, right? We have our able to demonstrate health literacy goal statement, which is a current existing SNOMED term, right? That there's not much to change there. It is what it is. And then next slide. Here we can see English as a second language programs, right? So we've already brought in any time we could assess any program being relevant from previous work. We folded it in. It's like a massive like baking exercise. You can tell I baked a birthday cake yesterday. Yes, Rita, you're exactly right. That within those situations where the primary barrier to understanding is just a simple language barrier, we do have referring to English as a second language programs as an intervention. And we see just from a digital literacy perspective, we already had digital literacy as a program within our education domain as well. This remains a program here too.
Sarah, what about providers who are depending on children to be the health literacy element when dealing with a parent? Does that come in here at all? And is that considered ethical by everybody on this call? And in general, is that something to be raised within this subject, within this topic?
That actually goes along with what Tom is saying right here. So Tom is saying very wisely, we should add translation services as an intervention. Tom, can you be so kind as to submit that, my friend, just for our process perspective? I know you can. Yep. You're also part of the interventions work group, so I'm going to ask you that same question next week.
Okay.
I'll get you then. I don't need to have you submit it. Okay. So Lucy, I think that would be part of a translation intervention, right? Is that what you're?
Yeah, I guess that would be one way to address it.
Yeah. And again, if you have any other ideas, and yes, translation services across different modalities of learning and communication would be required. Wonderful. Okay. Lovely. Okay. Next slide, please. Okay. So some things that we've come to is, Lucy, this goes to what I was saying to you. So we need to account for screeners that do not include those who are not fluent language speakers, because otherwise it's just perpetuating bias. So we're really trying to figure out and include from a health equity lens, like any kind of screening methodology that allows people to meet them in their primary language. We really are focusing screeners and ensuing diagnoses from a simplicity standpoint. We started with a whole multitude of health literacy domains, and we really are narrowing the focus only because we don't want to create terms that are completely abstract to the user, and we can always expand them. If we build our terminology correctly, we can create subtypes over time. We are prioritizing and focusing on organizational health literacy assessments and interventions, even though we said we were cautious because we've been told we really should. And then we have decided right now to move digital health literacy to a subtype of digital literacy. And then this goes to the commenter because of its unique intervention types. And we already knew we had digital literacy as its own goal and digital equity as its own goal. And so we're just going to put a pause on that right now, even though we know how critical it is, especially in this moment in time, because we really want to make sure we gather all of our digital experts when we really thoroughly dive into the interventions for there. So that's on our roadmap for the future. Any concerns there? We are definitely using our time, but we're going to be okay. Next slide, please. Yes, Tom, yes, indeed. Trainings for healthcare providers as an intervention for organizational health literacy. That sounds fantastic. And offering tools in different languages, right? All of these things are things that we're going to lean on your wisdom and expertise to help us in the interventions work group. If anybody, again, though, has any ideas about critical interventions across health literacy programs that might be important, terms, screeners, just submit them. Okay, next slide, please. I think about also the role of patient advisory councils with organizational health literacy, just from a NCQA, best practice perspective, Joint Commission perspective. Utilizing the feedback from patient advisory councils has been a pretty significant step forward with our organizational health literacy movements in my little clinic. Okay, health insurance status concepts. Next slide. So Suzanne's asking, are there levels of health literacy terms, basic versus, so many of the tools use low or marginal health literacy. So it's almost like the assessments across a spectrum, just like we use with food insecurity. So if you look in the literature, if you do any of the more robust health literacy questions, you do get a spectrum. The problem is many of those more robust ones are really cumbersome and very, very long. So you might not be able to implement them. So with our current kind of brief ones, not dissimilar from the two-item hunger vital sign compared to the 18-item USDA gold standard screener, you might just get a problem with health literacy without being able to do the spectrum on some of our shorter tools. Okay, so health insurance status, this is just a document of covered yes or no. So we covered this slide before. Next slide, please. I'm just making sure. Yeah, so if you have any other ideas, again, we do want to state that making sure that we address organizational health literacy and doing organizational health literacy is new for us. So if you have any submissions for interventions, please submit them on an organizational level. This is the why. We covered this before. Next slide, please. This is an update on some of our diagnoses we're working on. So we do want to state that uninsured medical expenses might eventually be moved to medical cost burden. This is kind of a work in progress. This is just based on our search. A very basic statement of in SNOMED that for the absence of health insurance, which is the primary problem, would be lack of health insurance. Over in ICD-10-CM, the reason why this is grayed out is this is often stated as the best way to code lack of health insurance. It's really awkward and not a very good use of this term. So we include it only to say we found it. We know it's often used. We don't think it's good. So we're going to work on something better. So it's not in the master. You're not going to see it, but we just show it for reference. So our primary things that we're working with right now that exist are on the SNOMED CT side, even though that term might move. And then we really are suggesting some kind of clear documentation of the absence of health insurance, although the wording might change. Next slide, please. So these are statements of goals that we call basically where we're headed from the problem. So all of the things in bold again exist. Patient has private medical insurance, employee group health insurance coverage. These all exist in SNOMED CT, but there's no general concept of has health insurance, right? So we will have to develop some kind of general parent statement, and then you could have all the subtypes in the world that you wanted, but there would be some kind of general statement to do what we call the easy button. Even though from an admin perspective and mapping admin terms over to the clinical terms, all of the different subtypes might be appropriate. This current representation within SNOMED CT is so partial when it comes to the US terms. So we do need a general term just to document its presence. Thank you. Next slide, please. So Lucy's saying, Tom, could you include that the idea of using children as unpaid, unlicensed translators is not okay? Lucy, I'm just going to echo, it's not okay, right? We know from best practice, we're not supposed to use family members as translators. So we will certainly make sure that that's included in our definition and our approach. Okay, next slide. I want to make sure we get through medical cost burden. Sorry, I feel like I'm rushing. I don't usually rush, but this is what happens when I go second. Medical cost burden. So Tom's saying, reviewing the screening questions you shared earlier, it suddenly hit me that they're focused on understanding personal health conditions and communication between a patient and provider. But there's nothing about understanding health insurance, what is covered by insurance, and how to navigate insurance billing. Fascinating, right? So I'm trying to remember, there's a lot on the master that I did not include in the slides. I'm trying to remember if there are screening questions and answers that address elements of billing. I'll have to go back and look. And then we'd have to figure out if that would be included within health literacy or whether it would be a different subtopic. But that's a good point, Tom.
Yeah, it just comes to, it just struck me so hard because I kind of come from a family that has a health and medical background. So I have a great doctor, wonderful communication. I can't for the life of me figure out without a lot of effort, is this medication going to be covered? Is this, you know,
You and me both, Tom.
so, you know, it might be in the interest of everyone, you know, providers and patients to start evaluating the information that's provided by insurance companies for comprehensibility and usability by everybody.
Yes.
Let's start holding them accountable.
Yeah, that's
even clinicians don't understand.
I know. So I mean, how many times do I'm like, who the heck knows what's going to happen when I prescribe this for you? I don't know what's going to happen next, right? So
this is Janice. I'd like to add to that. Yeah, hi. When I signed up for Medicare, I really researched, you know, if I wanted to stay with my current provider, and I was just shocked to see the difference between the plans and some of the plans that might have been better in some area where the medication might cost me $350 for like eye drops. But at my, you know, for Tobradex, anyway, it's crazy. But at my, I stayed with the same as like, you know, $15. So I found that the plans that were more reasonable, you know, that have a lot of the extra SDOH stuff, but a lot of the people are on Medicaid. But if you're going in as a private buyer, it's very costly, and you really have to look through every single you know, it's not fun anyway.
Yeah, and I just want to totally support and echo that. Whether or not it's part of this domain, we have to figure out. However, Tom, you are correct 100%, right? So we have a parking lot. It's just, I'm trying to figure out what to call that. But maybe Tom, next week during the interventions meeting, you can help me parse that out a little bit. Again, I don't know if it's necessarily included in the screening approaches for the universally understood and defined, you know, personal health literacy, but it's absolutely a critical topic. And as Bill keeps saying, it's across all members of the team, right?
Well, I think if we think about it in you know, a more inclusive context, if people don't understand what kinds of health services they can access with the insurance they have available, how does that affect their ability to, you know, secure and take proper medications, to engage in, you know, appropriate health behaviors, and to actually seek healthcare when they may need it, out of fear of not being able to afford it. So yeah, these intersect, but I'm not sure how. I'll start building a soapbox to climb on next week.
I love it. I love when you climb on a soapbox. It's like one of my favorite things. It's very appreciated. Actually, I wouldn't call it a soapbox. It would like you have the podium, Tom, right? So, okay, so we're holding space for that, right? Knowing that we've identified it as a critical gap and, you know, kind of a modifying factor for all of these different things we're talking about. I'm going to move through medical cost burden just for the sake of time, but everyone know that in the grand parking lot of parking lots that has been placed there, we need to figure out whether it's in scope for health literacy, which based on the current definition and the current screening methodologies, I don't know if it is, or if we need to make its own space. All right. Yes, Carrie, absolutely. The surprise billing element. Absolutely. Okay. So we're holding space for that. Medical cost burden. Next slide. All right, so this is the measure of financial pressure resulting from health spending stemming from inadequate resources to meet medical cost needs. This lovely question set is from Carabello et al. It's really powerful. It talks about a problem paying for bills and paying things over time. It's really those out-of-pocket expenses. And the last question would be a severity question. Do you or does anyone in your family currently have medical bills you're unable to pay at all? Next slide, please. All right, so this text is kind of small, very timely, a very sobering release from Kaiser Family Foundation on the burden of medical debt in the United States. I want to thank you, my dear friend Asha, for snagging this off Twitter and dropping it to me. So according to the 2017 U.S. Census, 17% of U.S. households owed medical debt. And then the Kaiser Family Foundation analyzed the survey of income and program participation and found that 23 million U.S. Individuals owe significant debt, 16 million owe over $1,000, and 3 million owe over $10,000. Next slide, please. So one of the things, this is just kind of deepening the why. It was just very timely, right? So this is, again, building off the same study. So at increased risk for having medical debt are people with disabilities, those in worse health, poor or near poor adults, Black Americans, and people living in the South or in Medicaid non-expansion states. Next slide, please. It is so jarring. Yeah. So this is just continuing. So this shows the data along the federal poverty line, and then this shows medical debt by health status and disability status in 2019. So those with poor health status, 21% of them report medical debt. Yes with disability, 15%, no without a disability, 7%. So very timely, very sobering study from Kaiser Family Foundation regarding the presence of medical debt. And kind of driving the why of this health domain, of this domain at this time. Next slide, please.
So, Sarah, what are going to be the interventions for this? I mean, we've all known this for decades. So this comes up under SDOH screening. And then what happens? We all march on Congress to do something about this?
Well, sure, yes, right. That's the,
That's an intervention. Would you please put that on your list?
I will. I mean, when we're thinking again, the anchor for this work for me is the World Health Organization Conceptual Framework for Action on the Social Determinants of Health, right? It clearly states that healthcare providers have an ethical mandate for working for structural solutions for social determinants of health in line with understanding their outcomes on health status. Purely, it's like you need to go fight for policy changes. So the World Health Organization said it was so. So yes, absolutely. But also when this happens in my clinic, I literally have a mind map and a resource map that I do. Like there's hospitals I send patients to, there's the grants and nonprofits I send patients to get their costs covered. There is 1,000,001 different programs. I even have patients sometimes transfer care from my office to a different office because the FQHC, well, soon I'm going to be an FQHC too, but there is a really sobering and sad process that we go through in order to meet the horror of this kind of debt with an individual. So there are things that we do, and those are things that we already had really in our financial security and financial strain elements from a year ago in our material hardship domain, but we weren't specifically and well enough covering medical cost burden at that time.
And along those lines, I can remember the meeting I was in that someone from ONC was talking about the difference between the amount of grants that's available to support medical cost burden and the people not just utilizing them. And it was shocking to be able to hear that, and knowing that several people who might be able to take advantage of those types of opportunities. How do we pull all of those grants and programs together and make it accessible as part of the intervention for this? And how do we assess? Because sometimes it's hard, enough as a clinician just working with a particular patient to be able to assess that at that point of care. How are we thinking about translating or even investigating after the fact? Because the patient might not know how much the test costs until they show up at the labs, or they don't know how much it costs for the medications until they get to the pharmacy. How do we bridge that gap of the in between the visits when they're being hit with that cost burden?
There are some policy changes, the price transparency rule that state that, patients should be able to know the cost of things before they do them, right? So there are policy movements from a patient driver perspective that really are trying to make it obvious. You know, it's still not. I feel it depends on the setting. But Billy Keys, I'm just going to totally support what you said. Again, it's a little tricky in gravity because we're tool builders, but you know, the enabling the you know, we are in our implementation depth is kind of limited only because of our scope of practice is to develop the terms, but we look to our community partners to be able to do that. And then this is partly, again, why, you know, we see across healthcare reform and value-based primary care, you know, kind of a differentiation between hospital primary care and FQHCs, because the middle folks get crunched, basically, when it comes to intervention finding for a lot of these things we're seeing. Anything else to say regarding that? But like, Keith, anything else we want to add there?
I just typed it in the chat. What happens in between those visits? That's my concern. And how do you set up a visit specifically about, you know, me not being able to afford my meds to be able to connect me to that program that might be able to help solve that? A lot of patients would leave, and when they discover that they're unable to afford it, they just don't show up, and they're just lost to the visit. That's sort of where I'm coming from. But to your point, I know that a lot of EMRs are incorporating sort of a suggested amount in the, you know, or maybe probable costs in, and some of the tools that our team is creating around CDS. We're trying to work with Medispan, work with SureScripts and so many others to just figure out how much medications would be before the patient leaves. But it's sometimes just really hard to pull all of those together.
Yeah, I do want to echo what Marianne Berger is saying here. This is where, you know, those community health workers and, you know, the referral tracking is really important. It's also just sad that we have to do this. I think Tom was saying, frustrated observation, do U.S. citizens realize the complexity and personal cost of healthcare is not an issue in most of the world? Yes, Tom. And the amount of effort that's expended to navigate through an overly complex and unjust system is noted by all, right? There was just even a really amazing study put out by about the, I mean, there's the 1,000,001 studies to talk about how to address this would really be universal coverage, but sigh. All right. Okay, so I'm just going to quickly go through the rest of the slides. This next slide really, so this is the unable to afford element of medical cost burden. We're parsing this out with our subject matter experts. Next slide, please. One of the things that if we really think about and focus on the specific medical cost burden experience, it really would more be appropriately stated as excessive out-of-pocket medical expenses, excessive medical debt, and we already did have a term from our previous bill, the financial insecurity due to medical cost burden. So these are all, you know, possible terms within the SNOMED CT, and we'd have to consider whether there would be appropriate term with an ICD-10-CM. But this is, again, our first attempt to kind of get some terms in front of you for medical cost burden. Next slide, please. And then, as I mentioned here, our next work is to work with SMEs to differentiate inability to afford, which is material hardship, from presence of medical debt, which is medical cost burden, just to make sure we get that right and sorted tidily. Again, this is partly why we revisited it, because we've expanded the domain of material hardship a little bit, and because there was a submission for ICD-10-CM that grouped together a lot of different concepts regarding health insurance insecurity, and we wanted to make sure we parse them out and address them in time. All right. Okay, next slide. I think we are, oh, here's the goal. So our stated goal is for right now, for medical cost burden, would be able to pay for healthcare needs, right? Very simple and straightforward.
How about reduce the cost of healthcare?
Yeah, that can be a great one. We can do universal healthcare. That sounds fantastic. We can make that is the next goal.
I mean, as long as we're talking structural reform.
No, I know. Why not say it out loud? That sounds great. Great. All right. Next slide, please. All right. Any questions on what we've just covered? We've burned through a lot of material because there was a lot to cover. We've covered health literacy, health insurance status for medical cost burden. You've heard my very next slide, please. This is kind of in the Oh, this is the Interventions Council. If you want to be part of the Interventions Council, send us an email. Gail, I really want to talk to what you're talking. I'm going to do my little closing statement, which is, please, please, please send us screeners, questions and answers, submission terms, anything. Absolutely, we need your help, right? This is how you submit terms. This is how you review what's out there. And then if I can't make it any more plain, we absolutely need you to do this, both for the proof of our concept, which is that we are a collective, right? And we collectively submit and create our data sets. And just because these, like specifically within health literacy, we really need those brief screeners. I'm gonna answer Gail right now. I heard you mention American Community Survey and U.S. Census during presentation. Can you reiterate the plans for standards for additional surveys asking for a friend? Gail, we got your email. Hamali is working on a project regarding all of the standardized surveys and has a specific email coming soon to your inbox.
Which is wonderful. Thank you so much. I really enjoyed the discussion today. You guys are brilliant with everything perspectives that you bring to all this. It's really fascinating.
Thank you, Gail. Really such an amazing partner. Thank you so much. The one thing we wanted to say is that we do ask whatever group you're working with to submit the terms they're using, right? So we are going to do we're going to analyze the community survey, but if anyone out there is using anything, including whatever partner you might be working for, asking for a friend, maybe you could submit it on their behalf. Just again, because that burden of use, if this is being used in blank setting, is really important for our model and our process. Does that make sense?
Will do. Yes, that's great.
Awesome. Thank you. Thanks, Tim. Submit concepts. That is the final statement. Next slide, please. All right. Okay. Join us. Reconvene in 2 weeks when we meet again. Join the Fire ID work group every Wednesday. You hear Bob talking about how they're doing ballot reconciliation. This is our team, our amazing team. And we just are very, very grateful for all of you joining us today. Happy St. Patty's Day. And we hope you have a lovely weekend.
You too, Sarah. Thank you so much.
Thank you.
Thanks, Sarah.
Thank you. Bye.
Bye,
Thanks,
friends.
Sarah.
Thanks, Sarah.
Great job again. Thank you.
Bye, friends. You have a lovely weekend. Thank you.